That's where we are. I think in May, in the World Health Assembly, the document on people-centered, they want to call it people-centered healthcare, will be signed. And I think that's where we can take off. And I'm really very glad that for the first time, the patient groups are involved in forums and forums such as this. I don't think I saw this in my lifetime in the pharmaceutical industry. Was as he said, Duque was saying he did invite patient groups. But said the problem was in the past it was consultation. When everything has been in place. What we'd like to see is in the conceptual phase, the patient groups are involved, and even in some processes within the government regulatory functions. For example, regulatory formulary, the benefits committees within PhilHealth, other committees within the system.
Ma'am, do you want to comment as a user or representing infants and neonates?
We have a small NGO that looks after mother and babies. It's non-pork and non-dairy. So we started our work back in Secretary Duque's time with what we coined as Unang Yakap. And basically, this was designed, and the analogy I'd like to use is that we cast safety nets to go after low-hanging fruit first. The newborns that could be saved with simple, low-resource measures like convincing facility workers of the Rasuman to change their behaviors around the time of birth, around the time that mothers go into labor, to stop pushing on their wounds while they go into a contraction, to allow them to sit up, to foster more humane care, because it's not true that if you build them, they will all come. They have to be respected and not criminalized, for example, if they have undergone an induced abortion. So standardizing care in the labor delivery and the immediate period after a baby is born is what we try to do to save low-hanging fruit, newborns who are easier to save. Not the tiny prematures yet, but getting health workers to change behaviors, getting them to wash their hands, getting them to allow women to stand up, etc., and bear down properly. So the safety net, I think, has been cast. We have developed technological packages that we are training health workers with. We have standards of care, but the safety net is not being, to my mind, being carried by enough people at the periphery. You can't have safety nets that have big holes and have only people in the center. At the periphery, what we've seen in many of the rural areas and even in urban core centers are that our health workers have learned helplessness to the way they behave, that they can't give oxytocin to help their uteruses contract within the first minute after a baby is delivered, because outdated midwifery law is disallowing them supposedly from doing so. When we went to a hospital in Cotabato, in a period of supportive supervision for these changes in healthcare practices, we asked them, are you still putting IV lines in all your babies? In all your mothers? And they said, no, we are not. Next week, so we were happy about that, but next week we came back and they said they were reinserting the IV lines after the delivery. And I said, why? And the reason was unimaginable if we had not been there in their meetings. The reason why they were putting IV lines in was that if the mother was unencumbered by an IV line, she would escape so that her bills. So it's a reason that you cannot comprehend, you cannot imagine unless you go to these places, supervise them how they change their practices, understand why women do do not want to access. Why will a mother who lives 10 hours upland in Malita, Davao del Sur, why doesn't she go down and go to the newly refurbished health center? So birthing mothers and newborns will continue to be the acid test of our health systems because they occur in narrow windows of time, but very wide geographic spaces. And the newborn, which is my particular stakeholder without a voice, is the canary in that mine. And we are losing our newborns, and we continue to lose our mothers because we think that what we have built in terms of safety nets have small enough holes, are built of sturdy enough material, and are held up at the periphery as they should be held up. That's all.
What I'm going to do is I'm going to pick up, I'm just going to pick up from what people have said, and then try to get the others to comment. But so far, the points that have been made is that there are a number of people in the country who really don't have access. Okay, there are people who don't have access. And there are people who may have access but refuse to go. The second is that there is already a broadening of access for certain diseases. Breast cancer was mentioned in particular. But having said that, one of the key points that was brought out was, one of the key points for access is patient-centered perspectives, which should be perspectives not only from the patient, but also perspectives that providers share. So I guess the question I'd like to ask now, broadening the discussion, is given these gains, we know that some people don't have access. We want to widen that access. We know that access can actually be expensive and has to be sometimes very specific for certain issues, certain localities. What are your views on actually widening access, but not only widening access, but widening access from the point of view of the patient who needs that access for everyone in the country? What are your thoughts on that? Maybe as an expert one, and maybe as somebody that's working in an organization or with government, where you're having to encounter that issue. So, Alex, do you want to answer first, and then we'll have Dr. Domingo.
First, I'd like to start by saying personal experience. I had hernia, and I had an operation. So I went into a private hospital, and after 6 days, after the operation and all, I spent $320,000, of which the PhilHealth benefit was only $22,000. So did PhilHealth help me any? Well, no. It was even less than 10%. And I think that contributed also to one of the statistics that was shown, increasing. But what was the point? The point was that I chose a private institution. I chose my own doctors, etc. And I knew that there would be expenses to be incurred. Many of the services that were given me, I did not choose. Diagnostics, for example. They subjected me to so many tests, even including my heart, my head, etc., that I thought was not needed, but anyway, it was still done. And then I came out of the hospital actually owning my pillow, getting free masks, face masks. I even got a towel, all for free. So that was the good part. Now, having said that, and that's already me. I'm the president, the CEO of PhilHealth. But in my receipt, it was not even reflected the correct PhilHealth deduction. The deduction should have been $22,000. But what was only deducted to me was $14,600. And I know what the difference was. The difference was because we also pay, part of our case rate is that 30 to 40% of that is professional fee. And that should be reflected in the billing, but it wasn't. No, but anyway, And here I'm already a lawyer, well educated, etc. And they keep telling me also